Good afternoon, everyone. Let me introduce to the speaker. Dr. V Surendranath. He is working in Medical Hospital as consultant. He has done DNB critical care. Previously, has done DNB anesthesia. Thank you.
Thank you for reflecting for giving me this opportunity. Just I have given a topic of around 15 days back by Vallachum Madam. Just give a talk on extubate of an obese patient to the NIV. I thought we will just in what went on my mind. We regularly use NIV in day out in every patient. Why they given this topic to me? Then I asked Madam, any literature supporting that why I asked this specific topic. Then I went in the latest 6 to 7 years of literature. But in 2023, one trial, that is the extubation in obese patients to the NIV. It is one of the positive trial they published by the French group of doctors, where NIV showed a good outcome on patient or obese patient who are extubated. Just I want to present with my clinical experience with one of my recently were treating in our hospital. This patient is a 44 years old patient of BMI of around 36, came with history of post-hysterectomy and suspected blood transfusion related sepsis, landed up in multi-organ dysfunction, came with high admission Apache score, and patient was deteriorating every day, and we dialyzed the patient, and patient had thrombocytopenia and anemia and transfused of blood and blood products, and we treated and in that community acquired type infection only. Then patient somehow improved and she is doing better, and patient now is planned for extubation, and her PaO2, SAPaO2 ratios also improved, and SOFA scores also in decreasing trend. Then our goal, patient is obese. If we extubate what would be the chance of the re-intubation in this patient? Definitely, any obese patient when we treat in the ICU, the one thing goes in the mind when we extubate, how we will manage the patient. If the patient is re-intubated, what is the outcome of the patient? Definitely, the previous studies showed re-intubation definitely has its own increase in mortality and ICU length of stay. And when the data also, the previous data also showed the patients who have old age patients and patients with pre-comorbid conditions as respiratory and cardiac disease had higher respiratory failure compared to the normal patients, because definitely patients who are in ICU had a decreased clearance of the decreased pulmonary clearance and low lung compliance, and patient may have inadequate cough and upper airway edema might be there because of prolonged intubation. These might be problematic when you extubate a patient in the ICU. And if the patient is obese, another additional factor also added. So, what are the things that after extubation, what are the devices you are in the regular practice you are having, where you can use it in the to prevent the post-extubation failure. So then we need a little bit of alveolar recruitment and prevent the alveolar collapse and reduce the work of breathing and support the patient for the better outcome. We regularly use the NIV. COVID taught us how to use the NIV and HFNC, and anyhow we use the nasal prongs and NRBM masks also. And we should always be aware of what is the pros and cons of every device what you use. And there is a obesity of two types. One is android type of obesity and gynecologic type of obesity. Android type of obesity has its own more impact on the patient during lung compliance and resistance. Whereas gynecologic type of obesity has less effect on our ventilation when patient is planned for extubation or any ventilation also. And definitely obesity increases the chance of patient has a high risk of wheeze, dyspnea and orthopnea, and patient will have high intra-abdominal pressure pushing up the diaphragm up, and patient have need more work, more energy to combat the resistance of the airways and open up of the alveoli. And from the spirometry point of view, patient definitely have a low FRC and low ERV. Lung capacity may not change much, but for us, we need the gas exchange. Patient will have a high closing capacity. The smaller areas closer very faster compared to the normal population. And the transpulmonary and diaphragmatic pressures may not be changed much as to the normal patient. This is one of the positive factors in the obese people, but overall obesity has its own, it's a chronic inflammatory state which it showed mortality in the COVID patients also. But when you use an NIV device in the obese patients, the transpulmonary and the diaphragmatic pressures will be less. The damage caused to the NIV to the obese patient might be less in compared to the normal population. And this is just how the patient is having high resistance, low compliance, and low FRC, and increased work of breathing, and ultimately CO2 rises, and the patient will have hypercapnia, and his brainstem has less response to the hypercapnia. And this is just how the obesity has how the obesity has a chronic inflammatory condition in the patient. And when you plan the patient to be in an extubate, definitely we need to make sure that all these parameters are met. Definitely the primary pathology has to be treated first, and patient should be ready for the ring. If the patient GCS is good and patient RSPA is good and behavior to favorability ratio also good, and patient is able to obey our commands and with maintain with the pressure support ventilation. There is a literature. This is the literature before this X-tube obese trial. This is literature given in the normal population in the ICU. There is a 2001 international conference showed that NIV has a promising therapy to prevent the respiratory failure. But in 2014, what they had done a meta-analysis, it showed even though the NIV supports those extubated patients, but it does not prevent the primary respiratory. It does not prevent the primary respiratory problem. Just it's only adjunct to give the betterment of oxygenation and the removal of carbon dioxide only. So if any patient would develop post-extubation respiratory failure, ultimately patient has to be intubated. It is not going to change in the any mortality and intubation rate. And another positive study by the Liu et al. Showed that NIV has a good effect in the reduction of icterectus in the post-operative patients. Another study by Ferrer et al. They conducted in the sick patients only. What they showed is patients were high risk for the extubation failure. They showed a positive response in prevention of respiratory failure, but not in a favor of mortality benefit. And this is one of the landmark study. Is a 2016. Is conducted by Thiele et al. This is mainly they conduct in the patient is having previous cardiovascular and respiratory diseases. What they concluded is definitely if you are anticipating extubation failure, preemptively after extubation keep the patient an NIV, definitely decreases the reintubation and reintubation and extubation failure also. So by these things, and the French doctors have conducted these one well randomized and pragmatic study in in the obese people. This is the obese people. They have conducted after extubation how the NIV is going to be helpful. They have conducted study in the 2019 to 2021. It is conducted in 39 French ICUs. They have taken all the patients who are more than BMF more than 30, and they have taken more than 1,000 patients. One good thing they have done is they have eliminated patients who are already having hypercapnia and previous usage of the NIV and previous history of obstructive sleep apnea and already tracheostomy patient. In 981 they divided into NIV group and conventional oxygen therapy group. In NIV group also, what the protocol they have written is the minimum time they have to keep NIV after extubation is 4 hours per day, and rest of the time they can keep one group of people they have kept on HFNC, another group of people they have kept on conventional oxygen like normal oxygen mask or nasal bronze. In the conventional oxygen therapy, half the group they have kept on HFNC and half the group they have kept on normal oxygen. So they extrapolated the results. They observed how the patients were seen in the ICU, and ultimately at the end of the study, there around 240 people were divided into an NIV with HFNC and 230 people with NIV with conventional oxygen, and 240 people around in HFNC and 240 people in conventional oxygen therapy. And there are around 70 people who are at oxygen therapy group. They converted into NIV. Those are shown hypercapnia and oxygen failure in the interim of the trial. One of the things how they included is the patients were having BMF 35 and with all comorbidities they are included in this study. And one of the things I observed in this study, the negatives are the most of the patients they intubated are for the procedures, and most of the patients are for the post-operative patients. That also gives some of the negatives of this study, because they may not be having the active pulmonary pathology. And the outcomes they are observed is the primary treatment failure in the NIV group. They showed the treatment failure in the NIV group was very less and it was statistically significant. But the reintubation not changed in between the NIV and the conventional oxygen therapy group. And the reintubation at 7 days and 14th day and 28th day and the ICU length of stay, there is not much difference between the NIV and the conventional oxygen therapy group. And they in the subgroup in the NIV, HFNC and NIV oxygen therapy group also, they didn't show much of difference. And definitely NIV showed a betterment in the prevention of respiratory failure compared to the conventional oxygen therapy. So by this trial, what concluded is NIV definitely prevented the extubation failure in the almost if you treat 6 patients, 1 patient can be definitely benefited. But the negatives of this study, most of the patients are intubated with procedures, and they included the COVID patients also in this study, because COVID has its own morbidity and mortality, and some of the cases were converted from the conventional oxygen to the NIV in the interim of the trial. Even there is not much difference between the reintubation in the both of the groups. So in the current study that X2 was dealt, that message is this much. I can extrapolate from this study that it is NIV is a preventive but not a curative way. Definitely the patient who are obese, who are unable to breathe properly, they may look obese, but the system may not maybe be they need some stick-like support to give. So definitely NIV may be helpful to prevent the respiratory failure. But definitely we need to monitor further what is the primary pathology is causing the patient to stay in the ICU and treat the primary pathology. And there is a score called HACCP score. This is to monitor the patients on the NIV. Because in COVID, what I learned is those are patients who are keep on NIV for longer duration of time when they showed signs of intubation. But if you are not intubated, they showed almost 100% mortality. So in 2021, they given this HACCP score. The patient who are NIV, treating on NIV, was where this is heart rate, acidosis and consciousness and oxygenation respiratory rate, which is increasing. If it is more than 5, better you go for the intubation and make the patient and target your respiratory ventilator parameters, that is plateau pressures, peak pressures, and prevent the lung injury. And this is the patient, this is the same patient. We extubated this patient, and patient was kept on NIV after extubation. Even the lung was there is no signs of any consolidation. So and the patient was hemodynamically stable, and patient was comfortable on the NIV. Thank you.
Good presentation, Dr. Surendra. Any questions from audience? Can we limit the questions for 1 or 2?
No questions. When is the lunch? And where is the lunch?
Okay, Satish, bottom line prescription for all the people to prescribe corticosteroids and community.
First thing is patient should meet the criteria to call it as a severe community.
All of you, please stay back for 2 minutes, please.
Patient should meet the criteria to classify him to be having a severe community pneumonia as per any of the guidelines. So once that criteria is met, start early steroids.
Actually, yesterday I have read an article where pneumonia is overdiagnosed. Every obesity is, they thought it as pneumonia. So first of all, the diagnosis of pneumonia must be, because connective tissue disorders or vasculitis, even organizing pneumonias, every obesity, they respond to steroids better rather than the bacteria.
That's what that study they included there.
So that is one. And your Cape Cod study very meticulously excluded viral pneumonia, even post-obstructive pneumonias, aspiration pneumonias, pregnancy, so many exclusions. So many.
Very stringent exclusions. So as a question is, patient should meet the criteria to call it as severe community pneumonia. So either it can be like a pneumonia severity index, or any should have some additional organ failures or something, because we need to have the criteria like having a patch, elevated TLC, fever is coming from the community. So all these criteria should be first thing. Second thing is start hydrocortisone as per the study. Maybe what the take-home message from that. Hydrocortisone as per the day protocol, the 200 milligrams followed by maintenance early within 20 hours. And maybe it is useful, sir, but otherwise.
Actually, when I was critically studying this Cape Cod study, in our setting, within 20 hours, we cannot exclude a respiratory viral pathogen. We don't get results, at least in our setting. Within 20 hours, tuberculosis cannot be excluded, fungal pneumonias cannot be excluded. So really difficult.
Yes,
within 20 hours, we have to start this steroid, including all these things, including influenza.
Yes, sir.
Right?
So maybe at this point of time, going case of community pneumonia, procalcitonin may help in that area, because it's very much well studied. Like PCT is less than 0.5 is non-bacterial, more than 2 high likely to be bacterial. Between 0.5 to 2 is a gray area, still we don't know. Maybe that. And one more thing, the other study they showed that CRP is more than 150. So take that.
And here the people should be, again, should be reiterated that 150 per liter
Yes, sir.
or 15 per deciliter.
Per deciliter, yes, sir.
For 15 per
For every
deciliter,
patient.
the reference is 0.6.
Yes, sir.
150 per deciliter, it is 6. So people should think, otherwise they might start it until it reaches 150. So that unit is also very important.
Yes, sir.
But do you think Meduri et al. Used methylprednisolone, is it right? Do you think that had the Meduri et al. People started pretty early, that is within 20 hours,
No, sir. No, sir.
within 20 hours, the same methylprednisolone
Sir.
for only 8 days,
Yes.
not a prolonged way,
Sir.
would they have made a better result?
I can extrapolate the same thing in the management of ARDS. Patient has gone into the ARDS, so there is a supporting evidence say that we can better to start steroids in ARDS patient before 7th day, and if you start it beyond 7th day, extending up to 14th day, it is a fertile effort first thing, because already as the pathological process is already happened and now it is going into the fibrotic phase, that is one thing. So taking that into consideration here, maybe methylprednisolone, equipotent dose of hydrocortisone, that is 20 is to 0.75 is to 4 is to 5. There is some dexamethasone of 0.75 is equal to 20 of hydrocortisone, 5 of prednisolone and 4 of methylprednisolone. If you take the equipotent dose of 200 milligrams of hydrocortisone, start early and give it for a limited period, maybe it is equatable to hydrocortisone 200 and the same study can be extrapolated.
Thank you very much.
Thanks.
Jekina Boyna Srinivas, who